A small introduction. So my name is Theodoros Mavridis. I'm a consultant neurologist. The two main interests are stroke and headache science. I have tried for many years to do research, and I made research on headache science. And also, I'm very interested in raising awareness. So we're going back to basics. We're going Migraine 101. This is going to be the first of a series of webinars that we're going to build. So if anyone wants to see those from the beginning, he can at the end of those webinars, because they are recorded. So let's get started. So headaches and migraine, it's not completely the same. So there is the broader term of headaches, and of course there is one subcategory, which is migraine. Again, migraine is something very specific. It belongs to what we call the primary headaches, which also intention type headaches or trigeminal autonomic cephalalgias, as we call them, TACs in short abbreviation. One of the most known ones, again, more rare than migraine, is cluster headache. And of course, secondary headaches, and we're going to talk the difference between the primary and secondary headaches. There are other facial pains and neuropathies like trigeminal neuropathy, trigeminal neuralgia, other entities that we haven't successfully validated yet, and they're a topic of research. So as I told you before, there are many types of headaches. Headache is the broader term. It is referred to pain located to the head, and of course, there can be associated with neck or face pain. And there is the broader definition between the primary and secondary headaches. Primary headaches are the headaches that do not have an underlying cause. And will think about that. We'll put some question marks on that, because not having an underlying cause, it means two things: either that there isn't any, or that is something and we haven't identified yet because the research has gone us so far. Secondary headaches are a result of another condition, usually causing pain or traction to some structures. Think of it like the headache that we have after a viral infection, or after COVID-19, or after a head trauma. So we know and we identify the underlying cause, and that's why it's labeled as secondary headache. Usually, not always, they are more sinister. So again, a rupture of an aneurysm in the brain produces a headache that the cause of it is very sinister. But you can have also milder headaches, like from sinus infection or viral infection. And now we're going to talk about primary headaches, and specifically this talk is about migraine. So we need to know what the problem is before digging into it. So the headache disorders are among the most common disorders of the nervous system. And according to the WHO burden of disease measurements, they come third after stroke and dementia. And they have not only personal and society burdens of pain, but also disability and financial costs. And we're going to talk more about them later. The problem with headache disorders, and specifically with migraine, it's that it's not appropriately diagnosed, and it's always underestimated, underrecognized, and undertreated. And I want to pause here and tell you something. Patients who suffer migraine, just because they don't die from that, it doesn't mean that it's not disabling. And it doesn't have to relate to death. Disability and years with living with disability also matter. And now we're gonna see the problem. We have a map here that shows what is how much of the people does it affect, and what is the disease adjusted living years. And with the red, the dark red, we see the countries that have the most daily disorder adjusted living years with migraine. And we see that Ireland and of course Greece, the country that I'm originally from, are with dark red color. And headache, we know that affects more or less a little bit less than the half of the global population. And it is estimated about 3.1 billion in 2021. We know that it's more common in female, and there are some differences between races, but there are only small variations. And we can see that it affects patients in their most productive years. We see with red and blue color the difference between men and women, but we see also the years that a migraine tends to appear. And that is more or less having a 42.1 million years living with this disability in 2021. And of course, it migraine itself, not from all the headache disorders, consists of 88.2% of the burden of the headache disorders. The problem, I told you before, it won't kill you. Migraine itself won't kill you, but it does has an impact on your life with decreased productivity and the two terms that we need to talk more about, which is absenteeism and also presenteeism. So absenteeism is that it's the days that you miss from work, and those can also result into loss of money, both from the patient and the employer. And presenteeism is a little bit different terms. So the patient goes to work, but is less productive. And it's very difficult to quantify that. How much is presenteeism? 50% less productive, percent less productive, but still it's less productive. So it doesn't do the work that it should do. And that affects also the care, and it also affects the career, the security, the financial situation, relationships, and mental health, because we must not forget also the comorbidities, especially in chronic migraine. And it's also economic loss to companies and society. And there are many papers, many scientific papers that try to quantify those and try to split those costs in direct costs and indirect costs. Direct costs are the drugs, how much they cost, the hospitalization, the GP visits, the visit to the emergency department, diagnostic tests, transportation to the hospital to the GP, or even need for childcare because the patient needs to go to the doctor. And they try to quantify that, and the total annual cost in 2021 in pounds were as seen in the right side of our slide. And the most important is that usually the indirect costs, the ones that result from presenting absenteeism, are much higher. There was a really nice study from in Spain, and they tried to quantify those. And those three graphs, I know it's a little bit troublesome, but let's go through each graph. The first one are the direct costs, okay? So I will show you, I don't know if you can see my pointer. Can you see that? So the pointer here shows the cost of a patient, the direct cost, who does not have any migraine attack. So patients who do not suffer from migraine. And we can divide them in hospitalizations, emergency department, and GP visits. And as we increase from one migraine day per month to more than 50 days per month, which means chronic migraine, we see an increase of costs, both the cost of ED visits, but also costs for in hospitalization, unnecessary most of the time. And here we can see the indirect costs, the ones that I told you before, that were the costs from presenteeism and absenteeism. And as migraine days go higher up, we can see an increase in the ED department, in the presenteeism costs, but not the absenteeism costs. Is that you go to your work, but you don't, you're not very productive. And that means less money either for you or even resulting to the boss firing you, or even less money for the company. And those are the total ones. So we're going to talk about migraine. We identified the problem, but we're going to talk more about migraine. We're going to talk about epidemiology, clinical symptoms. You need to know about your symptoms. You need to evaluate them. The axis of treatment for both acute and preventive one, other non-pharmacological treatments, and how do we follow up the patients. So migraine is a directly influenced complex neurological disorder. And I want you to know that I prefer to use the term syndrome because it needs criteria to be fulfilled. And it's not something that is with a causality, like you have a specific microbe in your body and that gives you a specific disease. You have to fulfill some criteria. So it's more of a syndrome than a specific disease. It's a neurological disorder. Usually the episodes have to be, they are usually typically unilateral. So it's one-sided, one side of the head. It doesn't have to be specifically in the frontal part of the head, temporal part of the head, or occipital, back of the head. But usually they're one-sided, but in many cases can be bilateral. So both sides can be affected, either frontal, bitemporal, or the whole head. Usually the attacks are moderate to severe headaches. So in the severity scale, usually there are more than 5. They're associated with nausea, sometimes vomiting, and you have that what we call in medical terms photophobia and phonophobia. They are Greek words, and they are a sensitivity to light and sound. Migraine comes from a Greek word called hemicrania, which you don't have to be very specific about that because there is a different term about hemicrania continua, a different type of headache. But when it goes to the Latin, it's called hemigrania, and then it came the term migraine. So we use the word migraine in English. And there are many, many famous people who suffered from migraines. Elvis Presley, Napoleon, Sigmund Freud, Nietzsche, John F. Kennedy, Darwin. And you can see that I put also Lewis Carroll's Alice in Wonderland. Many people think that Wonderland, Alice in Wonderland describes all the symptoms that can happen in a migraine attack, not only the sensitivity to light and sound, but other peculiar symptoms like metamorphopsia, the things that Alice was seeing like smaller or larger. So some people say that this book is the journey of a patient who has migraine attacks. And the same goes for Miguel de Fernandez, for Don Quixote. So we're going to talk about epidemiology. It affects, as I told you before, more than 12% of the general population, usually in productive ages, and there is a female to male ratio. We know that. We know that hormones play a role. Not exactly what role, but we know that it plays a role. And what about the etiology and pathophysiology? This is, as I told you before, it's $1 million question. Is a disease a primary disorder, a primary headache disorder? And as I told you before, it is a syndrome, so it needs criteria. We had found some things that can more or less point us to the right direction, but we're not there yet. So we know that there's a primary neuronal dysfunctions that changes both the intracranial and extracranial sensitization. We know about what is called the cortical spreading depression. It's a famous pathophysiology of the migraine aura, and we're going to talk more about it later. We know about the activation of trigeminal system, a very complex system, and due to our understanding of that system, new drugs like the anti-CGRP monoclonal antibodies that we have nowadays, also in Ireland, for the prevention of migraine, came from the discovery of this specific molecule, the calcitonin gene-related protein. We have sensitization, which is more often in chronic migraine, and of course, genetics and other reasons play a role. We're going to talk first about the triggers. Not all of the patients, but there are some patients who identify triggers of a migraine attack. So the most common ones are stress, menstruation, weather changes, fasting, nitrates, and there is a little bit more research that are more conspicuous on other triggers like wine or alcohol, specifically red wine with the flavonoids. Sleep deprivation is very, or sleep disturbances are very common cause or common trigger. And there are some others who are not completely identified, but many patients tend to tell that to the doctor, so we need to write them down. And what about the migraine attack? Migraine attack has, from some researchers, 4 phases, from others, 6 phases. I tend to use the easy definition, the small definition, the 4 phases. It's pretty easy, and we're going to talk more about it. So the main phases are the migraine prodrome, so before the migraine aura, which some patients do get that, some patients don't. It's only about 25 to 30% of patients get migraine aura. migraine headache, the pain itself, and then we have the migraine postdrome that can also result into cutaneous allodynia. So migraine resolution can also be a part of the migraine postdrome, and the interictal phase, which again it's the phase 6. I don't really count it as a migraine phase because it's the phase between two headache attacks. So the patient is completely normal, so it's not a migraine phase per se. So we're going to talk about those 4 phases. We're going to talk first about the prodrome. So the prodrome, it can begin about hours to 2 to 3 days before the migraine attack, and it has specific symptoms like yawning, mood changes, common food cravings, low energy, fatigability, sensitivity to light and sound, not as much as in the headache attack, but still neck stiffness and brain fog. Those are the common symptoms that can tell the patient that he knows himself or herself that a migraine attack is going to come. Not all people get prodrome, but if you ask the patients, the patient will tell you. And we go with it for the, we're going to talk more on the headache attack. I will leave the aura later on because it's very specific. So we're going to talk about the attack. So patients go from the prodrome to the headache attack, or they get the headache attack on its own without the prodrome, okay? So the headache phase, the main headache phase involves moderate to severe headache attacks that last from 4 to 72 hours. If it's more than 72 hours, then we know that it's a status migrainosus and has specific criteria to fulfill again. Usually it has throbbing or pulsating characteristics, like you're feeling your pulse inside your head. It can have also pressure-like characteristics, but still, as I told you, you need to fulfill some of the criteria, and I will tell more about that later. Usually it's one-sided, but sometimes can be both sides of the head. It's exacerbated by or causing avoidance in routine physical activity. So usually we ask the patients, we ask you, when you do get a headache and you try to do your normal things during the day, is it getting worse? Or even so, does the headache is causing avoidance of doing anything? You just need to be in a dark, quiet room. And it's also associated with 2 very common symptoms, nausea and sometimes vomiting. It doesn't have to be every time. And as I told you before, sensitivity to light and sound, which is called phonophobia and phonophobia. There are also other symptoms that we are trying to recognize, like osmophobia, which is a sensitivity to smells. Not smell as a trigger, but if you do have a headache, the smells can make it worse. And the other thing that we also recognize, that it can start in the headache phase, but also can last in the postdrome phase, is the cutaneous allodynia, which means sensitive skin to the touch, especially in the area that the headache was before. And you can have that feeling even with touching your skin, touching your hair, or even brushing your hair. Usually it lasts during the headache phase and during the postdrome phase, but in rare cases it lasts even longer, even in the interictal phase when the patient does not have any headache or other associated symptoms. It's more rare though. And now we're going to talk about the postdrome, which is the 3rd phase of the attack. It's what patients are used to call migraine hangover. So when you ask the patient and you say, there was a big attack, some patients tell you they have a big migraine attack, that it lasted for 2 days. But it wasn't just the migraine attack. After that, I have a strange feeling like I was after a party, I was hungover, like I drank too much, but I didn't drink anything. And that can last for 2 days or 3 days even. And in that specific part of the headache phase, you can still have mood changes, cravings, or brain fog. And it's very, very common, besides the cutaneous allodynia, the sensitive skin, as I told you before, to have what we call a pain that is triggered by movements of the head. And usually it resolves on its own, or if we tend to treat the headache early on, you might not have that stage as well. And now we're going to talk about a specific part of the head. As I told you, not all patients get that. It's the aura. So aura happens in about 20 to 25 to 30% of the migraine sufferers. There are recurrent attacks lasting minutes. They are one-sided and fully reversible. I will tell you what positive and negative symptoms mean, and I will have to tell you that it's more visual, sometimes sensory, or other symptoms, which is a bit more rare. It has to be gradual development. I will talk more about that. And usually, not always, but usually they are followed by headache or associated migraine symptoms like nausea, vomiting, photophobia and phonophobia, sensitivity to light and sound. Uh, I want to stay a little bit in the last one. As I told you, they can be followed by headache. It's not completely true. I'm not trying to trick you on that, but it can happen also during the headache attack, or it can overlap. So there was a previous term, the previous belief that the migraine aura has to stop and then the headache has to come. Usually it's an overlap of the migraine aura. As it goes down, the headache goes up, or sometimes it can be the same time. The most important thing is that it's usually one-sided and fully reversible, and usually it's positive symptoms. It means that specifically visual aura, will tell you more about it. It has black and white dots. It has to have zigzag lines that they are scintillating, and they leave that black spot after them. So we're going to talk about the different types of auras. The first aura, the most common one, is the typical aura, which includes the visual, the sensory, and the speech. A little bit more rare is the brainstem aura. Previously was supposed to be basilar migraine, but we don't use that term anymore. The hemiplegic migraine, which again is more rare, it's genetically linked. And something that I put in brackets and you don't need to remember is the retinal migraine. It's very, 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 very rare. And you don't need to think about it because, again, you have to completely exclude other causes because usually we don't end up having that diagnosis. So the typical aura, as I told you, 30% of the patients do have auras, and about 90% of them is visual auras. It's a fortification spectrum like a zigzag line that usually starts from the point of fixation and goes to the right or the left. So it's only one-sided and it's scintillating. As it goes by, it can leave a black mark in its wake. So it can be like it's a negative symptom, which is the black spot, but usually it comes with the bright flashes, black and white dots or zigzag lines, or the feeling that we have you looking through a kaleidoscope. So on the right side, you see pictures that were drawn by patients trying to describe what they were seeing. The problem is that when you ask the patient, especially if it's his first time that he had an aura, it says it's in both eyes, or it says like it's bilaterally both sides, which is not true because one side is usually affected. I will tell you more about the pathophysiology of migraine, of aura, or they say it's one eye symptoms. What they usually see, it's one-sided symptoms. Either they close the left eye or the right eye, but they haven't done that because it is more on the right and they say it's from the right eye, but it's not quite true. So this is a false perception. We usually, when the patient describes an aura, especially if it's his first attack. And there are some visual aura rating scales from the International Headache Society that are also validated. And that's what I use and other consultants use as well to ask the patient if he's seeing anything. And this is the image. Okay, the normal one is the upper left, and the patient can see any of those things, and those are regarded as auras. Usually, if you go to the fourth or the fifth, you see black dots, which is a negative symptom, but usually they have white and black spots, but the black is more prominent. So the patient tells you more about the black spots or the blurriness of vision. Okay. And migraine aura, typical aura, as I told you, the typical aura has three components: the visual, the sensory, and the speech disturbance. And why is that? The most common, as I told you before, is the visual one. And then some patients get sensory symptoms because it progresses. It's the first thing that I told you about the cortical spreading depression. And this is the gentleman who found that that it travels. It travels from the occipital lobe towards to the frontal part of the brain. So the occipital lobe is important for the visual symptoms. Then it goes to the sensory cortex, and then goes to the motor cortex or the speech cortex. Not the motor, I'm sorry, the speech cortex, and we have speech disturbances. So sometimes after the visual aura, you can have the sensory aura in succession after the visual one. Use moving pins and needles in one arm or one leg, usually the arm that travel, and you can have them also in one side of the cheek or one side of the lips or even the tongue. You can have a numbness after the resolution. So after the positive symptom, the pins and needles, you can have numbness, but usually it's not only numbness. And in rare cases, again, less often, it can develop that much that after the sensory part, you can have steep disturbance, usually slurred speech, as we call it in medical terms, dysarthria, or aphasia, dysphagia. It means you say the wrong words or you have difficulty in producing the speech. Again, more rare. Of course, patients who do have auras, it doesn't have auras in all attacks. Most commonly, they do have episodes, migraine attacks without auras, and some of them, they can happen with auras. It's very rare population, the patients who get pure and only migraine attacks with auras. Okay, so even the patients who do get migraine auras, usually they do have migraine attacks without auras. And another type of aura, it's the brainstem aura. Again, more rare. Usually the patients do have the typical aura. So the first one that I told you about, the visual, sometimes sensory, sometimes speech. Usually it's more the visual and the sensory. And people who have typical auras, they can have the brainstem auras. It's a little bit more common in younger patients. The symptoms can have, besides the typical aura, they can have slurred speech, spinning sensation of the room, not just feeling inside of a seat, spinning sensation of the room, ringing in the ears, increased sense of hearing, not just fullness of the ear, double vision, problems with coordination, and decreased level of consciousness. I must tell you in that point, there is no motor or one-eye symptoms in brain aura and in typical aura. So there is no weakness, but that's the trick. So many patients do have a problem in identifying if it's weakness or numbness. I will tell you more about that later. So in generally, usually the migraine aura comes before the headache, but as I told you, it can overlap or be into the headache as well. We can have two or more aura symptoms in succession, as I told you with the cortical spreading depression of Liao. So it comes the visual first, then you have a sensory, and then the speech disturbances. It spreads gradually over 5 minutes, not abruptly, like in split of a second. It lasts about 5 to 60 minutes, and if you have succession, it can be 60 minutes and 60 minutes and 60 minutes. So if you have the visual aura, 5 to 60 minutes, and then after the visual aura, I tell you the most extreme situation, then you have the sensory aura again 60 minutes, and then you might have the speech aura again 60 minutes. So it can last 3 hours, but again, this is the extreme situation. It's always that. It is one-sided, it has to be positive. So it has to have flashing lights or colorful lights. This is the positive, or the pins and needles. Not only negative, not only black or blurred vision, or not only numbness. As I told you before, the headache after that, or even during the migraine aura, can be just a headache. So it doesn't have to fit the proper migraine without aura criteria. The unilateral, the pulsating or throbbing characteristics. Unilateral means one-sided. The pulsating or throbbing characteristics, the severe intensity of the headache, or the nausea, or the sensitivity to light and sound. If you get a typical aura and then you get a small severity of headache, like 2 or 3 out of 10, it still fulfills the criteria for the migraine attack with aura. And in rare cases, I know that the headless horseman here, I know it originates also from Ireland. Some patients who do get migraine attacks with aura can get the aura without the attack. Again, usually it's in younger patients, but you need to have the migraine with aura in your history to say that this migraine aura, this aura was without the migraine. If you do get something that resembles an aura, but you didn't have any headache attack in your history, you need to be investigated. The hemiplegic brain is a little bit more rare. It's genetically linked. And besides the typical aura, because you have to have the typical aura as well, you have the fully reversible weakness. But this type of aura can last up to 72 hours, not only 60 minutes, and sometimes more. It's very difficult for the patient, especially if it is his or her first time, to distinguish from the sensory loss, from the numbness, from the pins and needles. And some patients say, my hand become weak. But if you dig more into that, it's not pure weakness, it is numbness, because he had strength. He didn't drop things, he had strength in his hand, but he couldn't feel it properly. And usually it's related to specific genes. So those are the 6 phases. Other societies use, as I told you before, the 6 phases. It's the resolution, which is between the acute phase of the headache and the postdrome. I usually put them together. It's sometimes some people get a sudden and acute end of the phase, and they have this acute urgency to sleep, or they are feeling good, euphoric, they smile a lot. Usually, I just put it together with a postdrome so I don't confuse the patients. And of course, the interictal phase, which is the time between the attacks. So the patient is completely normal, so I don't regard it as a migraine phase, a migraine attack phase, okay? And those are the diagnostic criteria. That's what we use in clinical practice as doctors, as physicians. And as I told you, diseases that have criteria are called disorders and are called syndromes. And those criteria is called the International Classification of Headache Disorders from this professor, Jess Olesen, who made the first edition, and now we have the third edition, and now preparing the fourth edition because our research evolves. We know more things about headache. And you see what are the most important. You have to have at least 5 attacks. So if you get only 1 attack, you have to be investigated. If you didn't get any headaches in the past, and it's on the first one, not the first one that sends you to the hospital or the ED, it might be a severe one. But if you had those in the past, even with small severities, less severity, and but they are more or less with the characteristics, and you had more than 5, then you do get the criteria checked. They last from 4 to 72 hours if untreated. So if they treated, they can last less. That's why we use the treatment to just break the attack. And as I told you before, it doesn't have to be one-sided or only pulsating, because in the criterion set it says at least 2 of the following characteristics. It means that you can have the moderate or severe pain intensity and the aggravation or causing avoidance of routine physical activity, and still the headache can be both sides of the head and pressure-like, but still you get 2 out of 4, which you fulfill the C criterion for migraine. And again, during the headache, it has to have at least 1 of those: nausea and or vomiting and sensitivity, plus sensitivity to sound and light together, not only one. Okay? And we talked about the headache. We know what the headache looks like, what a migraine looks like. Why is it important to diagnose it? Because we need to raise awareness and we need to educate not only the patients, but also the physicians. And we need to treat them early and manage it early. And why? Because we need to think of the first slides about the burden of disease. We need to prevent it to be chronic headache, chronic migraine. We need to think also about the comorbidities, especially in chronic headache disorders. And of course, another term that we're going to speak more, we're going to say more in further webinars, the medication overuse headache, which is more or less a syndrome that is developed from patients who need to take some medication, relieve the attack, the acute medication, but because they have an increased frequency, they take more and more and more and more. And then after a while, the same medication that you use to break the attack, it causes you, it alters the sensitization, the central sensitization of the brain, and it causes you a different type of headache. So the chronification, the chronicity, episodic migraine is regarded as headache days less than 15 days per month. And chronic migraine, again by the ICHD3 criteria, is regarded as headaches more than 15 days per month for more than 3 months. And of course, at least 8 of them have to have migraine features or treated by triptans, which is a migraine-specific medication I will talk more about later. It is highly associated with medication overuse headache because, as I told you, increased frequency of headache days results in the patient getting more medication to go through the month, and that leads to a poorly treated chronic headache that can also result adding up on top of that the medication overuse headache. We also need to think about comorbidities, especially with chronic migraine and in general chronic pain disorders. And the main comorbidities are fibromyalgia. We know that mood disorders, anxiety, depression, gastrointestinal disease, one most common is IBS, inflammatory bowel syndrome, cardiovascular disease, insomnia, and many more. And there have been many, many studies, and we need to tackle them both. So the treatment evolves around 2 axes. So we have the acute treatment of the migraine attack itself and the preventive or prophylactic treatment. And we're going to talk more about that. And we have also pharmacological and non-pharmacological intervention. So not everything is going around pills. Okay? So we have general measures during or before the attack. It's not very easy to do those. You have to try to avoid triggers if you know them, and if you can, of course. I know that stress is not something that we can avoid in everyday living, but we also use that as a prevention measure. I will tell you more about that. If possible, again, if you are in work, it's very difficult to do that, to try to lie down in a dark, quiet room. Make sure, this is the most important thing, make sure that you have access to acute medication, because if you leave the headache attack untreated for more than 20 minutes, more or less, then you get what is called central sensitization, and the drugs do not work on the receptor as well as they would have done in the early phase of the attack. Drink water, again, also as prevention measure, and try to sleep if that's possible. So for the treatment that we choose as physicians depends on the severity of the attacks, the presence of associated nausea and symptoms, and vomiting, of course, comorbidities, and the preference of the patient. General rule, we need to treat earlier, as I told you before. It's more, the medications are more effective when given early in the migraine attack, so we don't let the migraine attack evolve. We maximize the initial dose if needed, and we prefer to use one large dose of a medication we know it works than small repetitive doses that do not do anything but only adverse events. And we need to choose the proper route of administration, especially in patients who have nausea and vomiting, and non-oral administration like intranasal ones or subcutaneously can be an option. The pharmacotherapy is, we have, again, axis, non-specific, so it can help other diseases, that means non-specific, like paracetamol, or non-steroid and inflammatory medication like naproxen or ibuprofen or diclofenac. Specific treatments like triptans, a new medication that's called Ditan. The only one that is available is lasmiditan, again, not reimbursed in Ireland. And gepants, which is a new category. If you remember from the first slide, the new molecule, the CGRP molecules, we have many gepants nowadays available in Ireland. It's only rimegepant, but still not reimbursed yet. It got its reimbursement in the UK. It's around the corner of Ireland. It's used both in acute treatment and in prevention. Adjunctively, we use antiemetics, specifically for sickness pills, specifically for those who suffer from nausea and vomiting. We can have other treatments like blocks, especially if the headache lasts too long. So we block with lidocaine and steroids, the occipital and the great and the lesser occipital nerve. And non-pharmacological interventions, we have neuromodulation devices, The most commonly used is the cephalic, what we call supraorbital stimulation. We only have one. It's called Cephaly is the device. And again, the companies in the UK, but you can take it from there. Most of them were initially had one mode, so it was only either for prevention or for acute attacks. Now all three of them have dual mode for prevention and for acute attacks. What the patients need to know is that we need to avoid any opioid derivatives and any codeine-containing medications for two reasons. First of all, they do not work in migraine. Patients who do take them and feel better is because they dose them off. It does not act to the receptors of migraine. It can act very well into other types of pain, like somatic pain, like a toothache or something else, but it doesn't work on migraine. And second of all, it also increases the risk of developing the medication overdose headache, and then we have to detox the patients very, very hard, and most of them relapse. And the preventive medication, why do we use it for? Initially, it's for the reduction of the frequency of the migraine days, or in patients who do have increased anxiety or comorbidities. And the medication that we use or the treatment that we use, it depends again on the frequency, on the severity of attacks, if not properly managed with acute medication, of course, the preference of the patient, and comorbidities. And up until recently, and I'd say recently, about more or less like a decade, we had only non-specific medications. It means repurposed. They were made for something else. They are treating something else, but we found out, accidentally or not, that they work also on migraine. So we know that specific antihypertensive for blood pressure medication work also on migraine, not all of them. Specific antidepressant work on migraine, and anti-seizure medication work also for migraine. Different dosages on each. But nowadays we have also specific medication which is made only initially for migraine. The new anti-CGRP and receptor monoclonal antibodies, which are four of them, the eptinezumab, fremanezumab, galcanezumab, and erenumab. Three of them are subcutaneously, the fremanezumab, galcanezumab, and erenumab, and one of them is intravenously. And they have different profiles and different times of administration. It's either once per month or once per 3 months, okay? And the GPANs, as I told you before, rimegepant works both as prevention and as acute medication, but is not reimbursed yet. But the anti-CGRP monoclonal antibodies are reimbursed in Ireland. The problem is that they are expensive and you have to go through a reimbursement protocol, and you have to have failures or adverse events in other medications, not specific, initially to get the approval so the patient can have that medication. Also, for chronic migraine, we know that on botulinum toxin A injections work with a specific protocol that's called preempt protocol, and we use that a lot. Non-pharmacologic intervention we do is we tell the patients for lifestyle changes. We know that aerobic exercise and Pilates do the trick. We need to avoid triggers if there are any, and if possible, proper diet and alcohol consumption has to be limited, especially wine, but in general alcohol. Caffeine consumption has to be regulated. If the patient drinks caffeine, he has to maintain its normal dose of caffeine. If he or she wants to detox from caffeine, he or she must know that he or she will have headache attacks that are related to the caffeine detox. Usually they last about a week and then they go away. But if you do drink coffee in proper amounts, you still have to continue drink the proper amounts all the time. And of course, we have to tackle the sleep disturbances and sleep deprivation. There are some behavioral therapies, especially the cognitive behavioral therapies that help meditation. And again, the neuromodulation devices that are not as effective as the medication, but we use in conjunction or as adjunctive measures, or in patients who cannot tolerate or do not want or have adverse event on that, or even it's contraindicated, like pregnancy. treatment goals, what we want from a patient that we treat with pills or any intervention is that we need to reduce the monthly migraine days. And after that, the second endpoint is to reduce severity, to reduce the acute medication consumption, of course, prevent chronicity, chronification, and prevent MOH. So we need a measurement, we need a tool to assess that. We need the tool to monitor that, and we need the tool to know what to expect also for us and the patient. And because there is not exactly a pain meter, there is not such thing as we test the glucose from the blood, we cannot test that yet. So we have biomarkers that are coming up, but still on research purposes, and we can identify which patient is going to go better or worse with a specific medication for precision medicine, but we are not there yet. So up until now, we have the whole trail, which is the migraine diary. Can be either pen and paper or digital one. I know that the Migraine Association of Ireland has made also a collaboration with Migraine Insights, and they're building a new digital form of migraine diary. There are many out there. It doesn't have to be very comprehensive or very simple. But again, what to use? It depends on the case. So different diaries depending on the situation. If we are doing in a clinical practice and we have a lot of patients, we prefer to use a simple one. If the patient is contributing in a clinical trial, they have their own migraine diaries with many things to take into consideration. If we have a straightforward diagnosis, we don't need many things. If we know the patient, we just need the headache days, severity, if the medication works. But if it's a good case and we haven't made the definite diagnosis yet, because as I told you, everything is syndromes, so we need to fulfill the criteria, we need a more comprehensive one. And of course, depending to the preferences and if the patient is younger or more senior patients prefer the pen and paper ones, younger ones prefer their smartphones. So the more or less all the diaries must contain the number of days per month, the severity in a scale from 0 to 10. In little children, we do the visual pain scale, but we usually use the 0 to 10. The acute medication intake and the efficacy of those. And of course, you can add the adverse events of a medication, the symptom description in many words, associated symptoms like nausea, photophobia, phonophobia, trigger, other patterns, water intake, auras, if the patient has a migraine aura, hours of sleep, and again, sky's the limit. You can do it as comprehensive as you like, but still you have to individualize it according to your needs, not my needs. Your needs, and of course, it depends on if it's in a clinical practice or a clinical trial. So the keynotes of this presentation is to raise awareness. We have to understand your symptoms, and you are the only one who can tell us what are your symptoms. It's not us. You have the problem, and we need to understand your problem for us to solve it and to help you. You need to seek proper help, and we need to treat it early and effectively so that it does not go into chronic migraine or even more serious, the medication overuse headache. And we have to give your life back. Thank you for your attention. And as I told you before, this week is the Irish Migraine Awareness Week, and I'm very glad to talk to you, and I'm ready for any questions. I will give you my presentation afterwards, and it will be available. And if you have any questions, either ask them now or later, and I will be glad to answer it. Those are my two accounts. And before going to the questions, I need to tell you that we have more subjects coming on. It's going to be a whole series. We're going to build block by block all the things that you need to know about your headache disorders. And we have also the next subject is also on the making, but I want to hear your thoughts and your ideas on what should be the next subject or the subject after that. Thank you.